Okay, during this presentation, we're going to talk about autism from a genetic perspective. So recognize the risk of autism in patients with chromosomal aneuploidy, such as Down syndrome. Describe how array CGH can be used in the diagnosis of autism. Identify single gene causes of autism, including Fragile X and Rett syndrome. And recognize the risk of autism in both males and females with Fragile X syndrome. So autism is a common disorder defined as social impaired communication skills. And it occurs in about 1% of the population. Autism is 4 times more common in males than females. And 80% of patients with autism have a genetic component. Sometimes we can figure out what that is and sometimes we can't. Anyway, approximately 20% of individuals with autism have either a deletion or a duplication of genetic material that can be identified by microarray or array CGH. It's not seen by routine chromosome analysis. Single gene causes are seen in about 25 to 30% of cases. So at the best, 30 plus 20 is about 50%. So that leaves us about 50% of cases that we can't find the answer to. The most common single gene cause of autism is Fragile X syndrome. So when you see autism, think about Fragile X. Now let's just talk about recurrence risk, and this is just all comers. Once we've identified a specific cause, we can give more, better recurrence risk assessments. But if a child is diagnosed with autism, the risk of a sibling also being diagnosed with autism is approximately 4.5%. If there are 2 children in the family with autism, then the risk jumps to 25 to 30%. And this really has to do with looking at population data of all comers. If you have a child, what's the risk of having another one? This is looking at large population data. Once there's 2 kids, now it jumps a lot because most are sporadic, but some are inherited. If they're inherited, the inherited risk could be 25 to 50%. So that's why it jumps so much. But let's look at twins. Twin study, as comparing fraternal to identical twins, is a good way for us to, figure out what's genetic and what's inherited. Fraternal twins are like siblings. Identical twins have the exact same genetic, constitution. So fraternal twins, males, there's a 21% recurrence risk, and females, 27%. Autism is more common in males than females, so when females develop autism, there's more genetic factors to it. Whereas when you look at identical twins, 60% in females and 58% in males are concordant. So that means even looking at identical twins, even if we did not know the gene, there's a lot of other things that we don't understand yet that can increase the risk of autism. It's not 100%. Just as a quick review of microarray or array CGH, as I said, first of all, I want to talk about chromosomes quickly, which is 5 to 10% of children with Down syndrome will develop autism. We're not sure why, we just know that they do. There are a number of microdeletion disorders or small pieces of genetic material missing that can result in autism, and array CGH is the best method over chromosomes to look for this. Approximately 20% of children with a chromosomal, aneuploidy identified by array, with approximately 20% of patients with autism will have an abnormality on the chromosome microarray. We have, instead of culturing chromosomes, we're looking at fragments of DNA to see if there's any large or identifiable missing or extra pieces. We have our control. Here's our patient DNA. Here's our control DNA. Red plus green should equal yellow. We cut the DNA to small fragments. We put it on this. It's really it's not like a microscope slide as much of it is. Each one of these wells represents a certain sequence of a certain chromosome, and these pieces will hybridize. We then put it in a machine to hybridize it. If we see yellow, that means there's equal hybridization at that particular chromosome, that particular region of the chromosome. If there's a deletion, we get more patient, and if there's a duplication, we get more control. So we can look through the entire genome and see if there's any areas that have extra or missing. So common chromosome microdeletions seen in autism include Angelman syndrome, and it's the UEB3A gene, 16p11.2, Smith-Magenis syndrome, which is actually the RAI1 gene, or 17p11, and Phelan-McDermott, or SHANK3, which is 22q13. So let's first talk about 16p11. And until we started doing microarrays, nobody ever even heard of this, and it's now one of the most common causes of developmental delay in autism. That's caused by chromosomal abnormalities. Expressive language is more affected than receptive. They have microcephaly. They don't really have any facial dysmorphic features. And like I said, this is one of the most common causes of autism in children. And so it's an interstitial deletion, a deletion in the middle of 16, and it reanneals. Why that's a hot spot, I'm not sure. Angelman syndrome, I know we talked a little bit about this in the failure to thrive, but it's a deletion of 15q11.2, and it's the UBE3A gene, but it's also an imprinted gene. It's the maternal copy that is missing because only the maternal copy of this gene is on. Clinical characteristics include microcephaly, pointed chin, no verbal speech, joint laxity, severe mental retardation, unusual laughter, seizures, and difficulty sleeping. They used to call this the happy puppet syndrome. We've tried to get away from those particular names. Phelan-McDermott syndrome is caused by a deletion of material on the short arm of chromosome 17. So this is just a diagram of 17. So one of the copies has a piece missing. These are all the genes that are most commonly in there, but we actually think this is the critical gene associated with Smith-Magenis syndrome. Features include a flat face, prominent jaw, deep-set eyes. They also have poor sleep patterns, similar to Angelman's, but actually not quite similar, but they don't sleep well. They have a decreased sensitivity to pain, and so they pull out their nails and do things like that, and they eat non-food items, including paint, which is kind of a big deal. So kids with Prader-Willi eat food items, and kids with Smith-Magenis eat non-food items. Phelan-McDermott syndrome is caused by a deletion of 22q13. The reason we actually came up with this syndrome is because we used to use this region as a control for the 22q11. So let's say the 21q11 was green and this was red. When we did fish, we would see like 2 greens but only 1 red. And then they realized this is actually a deletion. What we technically was the control for this, but it's the SHANK3 that's deleted, and clinical characteristics include ptosis, or the eyes not opening all the way, a pointed chin, wide nasal bridge. Behavioral issues include behavioral developmental delay, absent speech, autism, and teeth grinding. So I now want to move to single gene causes of autism. There's over 2,000 single genes known to be associated with autism, and this number grows frequently. The most common two that you need to know, however, is Rett syndrome, MECP2, and it's a duplication or mutation of the gene, and Fragile X syndrome. So Rett syndrome occurs in about 1 in 10,000 females. As I said, it's a mutation of the MECP2 gene located on the X chromosome. Females usually have relatively normal development from about 6 to 18 months, followed by loss of milestones. One of the first symptoms is hand wringing, and you can see this little girl, she has Rett syndrome, and she's always like wringing her hands. Normal head circumference at birth, but then it slows and they become microcephalic. Autism with repetitive behaviors. Rett syndrome used to be thought to be lethal in males, But as we've done more and more gene studies, some, milder mutations, I guess you would call it, can result in survival of a male with very, very severe cognitive delay. So historically, it was only seen in females because they have two X's, but milder mutations of this gene can be seen in males. Fragile X syndrome is the most common cause of inherited mental retardation. So we're not talking about chromosomes, inherited mental retardation, single gene. It's the most common single gene cause of autism. It occurs in about 1 in 2,500 males and 1 in 1,250 females. And so it's located on the X chromosome. Why is it more common in females? It's milder in females, but they have two X's. This diagnosis should be considered in any child, male or female, with mental retardation and or autism. So let's talk a little bit about Fragile X syndrome because we've learned quite a bit about it over the last probably 20 years. And the Fragile X gene codes for FRM1 protein. And this protein is important in neuron function. The problem is when there's too many CGG repeats on the 5' end of this gene, we get no protein. So this protein's important in brain function, but if there's too many CGG repeats, we make no protein. The gene gets methylated or turned off, so you get no protein. Behavioral phenotype, language delays, usually noted around age 2. Autistic behaviors, including hand clapping and hand biting, are common. Poor eye contact. Hyperactivity is seen in 80%, and they also have obsessive compulsive behaviors. So clinical characteristics, prominent ears, long face, prominent jaw, joint hypermobility, and enlarged testicles post-pubertal. Remember we talked about Klinefelters have small testicles post-pubertal. Fragile X have large testicles. So I want to talk a little bit about the historical, why this is called Fragile X syndrome. Well, historically, they had children that looked similar to each other. And they thought, well, when they started doing chromosomes, let's look at the chromosomes. And while they had the right amount of chromosomes, one thing somebody noticed is there was this little fragile site, or this little, almost looked like it broke off at the end, in a significant portion of the males that look very similar. Again, loose ligaments, big ears, developmental delay, autistic behaviors. And so they used to do chromosomes. They used to try to do it in folate deficient media. It was really a pain and non-accurate test. Why this happened, I don't know, but about 30 years ago, they realized Fragile X was actually caused by too many repeats on the 3' end of the FRM1 gene. And when there's too many CGG repeats, it turns the gene off. So it's methylated, it's imprinted, it cannot be used. And so that is the problem with Fragile X. We do not do chromosomes for Fragile X. I'm just showing you this for historical context. So less than 45 CGG repeats, you're normal, and there's no risk for it to expand in the next generation. Between 55 and 200, there's actually an increased amount of mRNA. There's no cognitive delays. So here's the premutation. Here, less than we have a normal amount of FRMP. Here we also have a normal amount of FRMP. However, there's too many mRNA transcripts. And this can result in females with premature ovarian failure. Not sure why, just know there is. Males with something called tremor ataxia. And this can be misdiagnosed as Parkinson's disease. So a male, this is just how they might ask that question. A 52-year-old male or 60 or 55-year-old has a grandson recently, has, tremors, and then they'll give you more family history about how his grandson, his daughter's son, was recently diagnosed with Fragile X syndrome. This seems to expand more in females than males. So a female is at risk of offspring because it could go, once it gets to 55 to 200, it becomes less stable, and during oogenesis, it could go to a full mutation. And again, when there's more than 200 repeats, it shuts off the gene and there's no protein made. This is, as I was saying in the last slide, anticipation. So here's a father has 31 CGG repeats and the mother has 2 X chromosomes. One was 60 and one was 32. 60 doesn't cause her any problems, but it's an increased number of repeats. This can expand during oogenesis. So her daughter, it went from 60 to 80, and dad gave 31. And her son, and the son always inherits his mom, one of his mom's exes. Unfortunately, she gave this one. Dad gave a Y, and it went from 60 to 95. So again, it can go to different numbers. This 95 usually doesn't expand during spermatogenesis. So he gave this 95 to his daughter, who then fully expanded, whereas this sister, it can expand during oogenesis, and she went to a full mutation in this child. So between 40 and 60, no symptoms. 60 and 200, there's a risk of the premutation, tremor, ataxia in males, premature ovarian failure in females. Greater than 200, no protein is produced, and males have symptoms. About half of females have symptoms. So, in conclusion, autism is a clinical diagnosis. Once an individual is given that clinical diagnosis, genetic causes should be considered. And this also helps us, for instance, if somebody had, let me give you an example. If they were found to have a child with autism with a deletion of 16p11, which was de novo in that child, the recurrence risk of having another child with autism is not like 4 to 6%. It is less than 1%. However, if they had a child with Fragile X syndrome and the mother had, an increased number of repeats, the recurrence risk could be as high as 50%, depending on the number of repeats. So we would be better at determining the actual recurrence risk for that family versus just empiric data. The first study in any child diagnosed with autism should include microarray and Fragile X, and these 2 studies will identify approximately 20% of children. If these initial studies are negative, we usually do single gene testing of about 2,000 genes, which includes the MECP2 and all those other genes, and that identifies another 25 to 30. But even looking at identical twin studies, there's still 40 to 50% of patients with autism that no matter how extensive that we study, we're not going to find a genetic cause. So this is a USMLE question that I found in one of the books. A 7-year-old's brought to clinic for evaluation due to difficulty in reading. His teachers are reported his parent conference that he's unable to keep up with the rest of his class. His mother explains that he's generally well behaved, but does have odd tendencies of flapping his hands and getting nervous. Physical exam indicates a high forehead, prominent supraorbital ridge, protruding ears, and a prominent jaw. Formal testing identifies his IQ at 69. What is the most common or most consistent with it? What disorder is most consistent with this scenario? Down syndrome, Fragile X, Klinefelter syndrome, or Rett syndrome. So the correct answer is Fragile X. His IQ is a little higher than a child with Down syndrome. They're usually between 50 and 60, plus they usually have different clinical characteristics, a flat face, upslanting palpebral fissures. Klinefelter syndrome, their IQ is usually higher than 69. It's usually, around 80, 70 to 80, and they are usually taller, maybe have a little increased flexibility. And then Rett syndrome is, again, primarily seen in females, but can be seen in males, but more severe autistic type behavior. So that concludes this presentation.